Hello, everybody. Thank you for joining us tonight. I'm excited to be doing this, talking about applying flowable composites for everyday dentistry. I think about, my career as it's been. I graduated in 2001 from Temple Dental School. And initially onset was dead set on being primarily an aesthetic dentist in my practice. So I opened up a practice in Ponte Vedra Beach, Florida. I've been in practice, my own practice now for 10 years. And we started out doing primarily aesthetic dentistry. And then I learned that balance was key. And so I started incorporating more general dentistry into my practice to create more balance in my practice. And it's been a great go of it. But for me, it's always been about aesthetics first, but also it's important for me that things are efficient and predictable in my practice. And so today, I get the opportunity to talk about an Ivoclar product, which I do use in my practice. It's called Tetric EvoFlow Bulk Fill. And it's a great product, and I want to thank Ivoclar for giving me the opportunity to talk about the product, one that I use in my office. And in this format, this Viva Learning format, which is, I thought, super cool, to have kind of like this on-demand learning style that they have where you can see videos and you can see blogs and webinars like this one and getting together people all around the world. Like tonight, the people logging in, from all over the world. There's hundreds of people, and I just think that's it's a cool and exciting thing. And, so for me, this is about getting good results in everyday dentistry, not getting that post-op sensitivity, getting nice aesthetics, and utilizing materials that I've been utilizing for years and getting great results that we want to be proud of in our practice. For some people, getting nice tints and staining on the occlusal surfaces of the direct composites is what turns them on. And for other people, it's eliminating post-op sensitivity. It's for getting tight contacts, and that's the reality of it. I want to be able to place class 2 composites, and what's success there? My patients aren't in pain, following that filling. That they can have a tight contact, that food doesn't get stuck there. When they open their mouth and look, the filling's not gray and the filling's not brown. And if I've achieved those things then in an efficient manner, then I'm a great dentist. And so for everyday dentistry, that's really what I'm looking for. So today, what topics are we going to cover? We're going to talk about the properties of flowable resins. We are going to review the uses of flowable resins. We're going to talk about the transition to bulk fill flowables, which is a super cool direction which flowables are going in. I'm going to use a case to demonstrate the usage of a bulk fill flowable resin. In that case, I'm going to talk about how I get tight contacts, because the people at Ivoclar said, we love that you're talking about our flowable, but could you please talk about getting good contacts, because we get that question a lot. And I understand that. So I'll talk about the system, the Garrison band system that I use, the Garrison 3D XR rings, which give you those really tight contacts. I'll demonstrate the way I use that product in the case that I'm going to show tonight. And then we'll do our summary for everything that we've talked about. So what actually constitutes a flowable? That's a good question. They're in every contemporary dental office, but 15 years ago, they were absent from our bonding armamentarium. It was once written that these early materials, that the success of early flowable composite products was more a result of marketing than of any special properties beyond the flow. So what is the actual definition then of flowables? It's a low viscosity material capable of being dispensed into small preparations through needles or cannulas, usually 20 gauge, and low filler content, typically 20% to 25% less than non-flowable materials. So, and by the way, just because a composite is labeled flowable doesn't mean it actually flows. And that's actually could be good news, right? Because you may wish to use a highly flowable material, one with a low viscosity, with better wetting properties for cavity liners, but you may choose a thicker, less flowable version for, say, a class 3 or a class 5 restoration where the material won't run out of the preparation. And also, one might think that the more filler would yield a less flowable resin, but that's not necessarily true. The CRA findings show that the highest filled flowable was in the top 3 for most flowable, while several products with lower filler amounts didn't flow at all. So let's talk about that low filler content. What happens to the material because it has a low filler content? Well, traditionally, there's higher volumetric shrinkage, there's a decreased wear resistance, they're more polishable, and there's higher flexibility, so there's a lower elastic modulus. Volumetric shrinkage is estimated to be at about 3.8 to 6.4%, which is 1 to 3% higher than non-flowable materials. So what's the problem with volumetric shrinkage? Because we don't like the idea of the shrinkage factor that's happening on the teeth and what it's doing to the teeth. What exactly is happening? As the shrinkage stresses are transferred to the tooth, deformation of the tooth occurs. And in doing so, this may result in postoperative sensitivity, opening of microfractures, bond failure, microleakage, and it could lead to recurrent caries and deterioration of the restorative margin. Now, it's surmised that the lower elastic modulus, the lower modulus means it's a higher flexibility, compensates for the higher shrinkage. And so when we look at the C factors, this is a good review to talk about C factors again because some of these come up from time to time. C factor means configuration factor, and it's an estimation of the stresses generated through a given cavity configuration by a ratio of bonded to unbonded surfaces. The higher the C factor, the higher the number of bonded surfaces, the higher the stress generated. So class 1 preparations have a C factor of 5. There's 5 bonded surfaces and only 1 unbonded surface. So the net result of the C factor is 5. So for flowables, they are less filled, less viscous materials that can be syringed into small preparations. Because of the high shrinkage and low wear resistance, the choice of applications for early flowables should be limited. Each incremental depth should not exceed 2 millimeters. So that's traditionally the way we would think of flowable materials. We would have to incrementally place these in small amounts. Really, the smaller amount, the better, to eliminate the shrinkage forces that were occurring and to avoid that all those things that could lead to failure of the restoration. So the uses of the traditional flowables would be limited to lining of class 2 proximal boxes, cavity adaptation, repair of bisacryl provisionals, amalgam repair, and restorations of small non-occlusal bearing lesions. And so for a lot of the statements that I'm making, I needed to pull some references, and look back in literature and see, historically the way flowables are used, because I don't use flowables in all these ways, and so it helps for me to pull literature to find out the way that people our dentists are utilizing flowables in their practices, and they're all ways of utilizing these flowables. So let's talk about these uses of flowable resins. As you see in this picture, this is a picture of placing a flowable resin, which is used as an opaquer or a highlight to make the filling a little bit more three-dimensional in appearance. The uses of flowables, just pulled a list that I saw that I thought was really encompassed a lot of the uses that we have. Cavity liner before placing a paste, before placing like a universal or a packable composite, abfractions, erosions, and class 5 restorations. Being is that they're a more flexible material, historically we're thinking that that flowable resins are good to place in non-carious cervical lesions, which could be contributed to abfractions, which is that force placed on teeth, that flexural force placed on teeth, creating a non-carious cervical lesion at the gum line, and that would help the material stay in the root surface lesion, not come out, reduce sensitivity. So a lot of dentists like to use flowable resins because they're flexible for those situations. Small class 3 restorations, Remember, they're staying away from occlusion because of the wear. Repair of small defects and restorations. I did that today in my practice. Pit and fissure sealants. Preventative resin restorations. So these are very small occlusal fillings which are not in occlusion. Fabricating temporary veneers. Now, I saw that one. I thought, no, I've never actually tried to create a temporary veneer with flowable resin. However, I will show you a technique where I use it as a temporary cement when cementing on provisional veneers. Bonding porcelain veneers. Any microdentistry, particle abrasion and laser cavity preparation, tunnel preparations. I mean, being delivered in the small tip makes it easy to access certain areas that are difficult to place traditional composites in. Creating reservoirs on plastic models for custom bleaching trays, opaquing metal substrates. When we have porcelain breaking from implant bridges, obviously I'm thinking of something that's happened, in the past few days. Being able to opaque out the metal substrate with a flowable material before placing a composite material on top, a highly polishable composite on top. It's the difference between getting repair on a bridge that looks very aesthetic, like nothing happened, or getting repair on a bridge that looks a little gray. And so, as I said, patients don't like to look in the back of the mouth and see brown or gray. So that helps a lot in those situations. Utilizing it for periodontal and orthodontic splinting with fibers or wires. Repairs of voids or discrepancies in temporary crowns before cementation, and denture repairs. So many companies offer different shades of paint, tint, stains, and opaques and color modifiers. And so there's many different uses for flowables for sure. And so one technique that I have, in my practice, I have a patient who had 10 provisional restorations. They're conservative veneers. Left the practice, of course, with the instruction. You tell him, don't bite into anything with your front teeth. And, he comes back, maybe a week later, he bit into a roll, and the excuse is, well, I thought it was a soft roll. And so the roll wasn't soft, it was a hard roll. And so, the home care instruction there, maybe out the door a little bit, but it happens in practice. So how do we handle it? In a situation like this one where the provisional units were still had by the patient, he brought them in with him. I was able to just load a flowable composite inside the provisional veneers, seat them back over the teeth, and do a wave and clean the excess, and then do a final cure. And with these flowables, this happens to be Tetric Evo Flow. With these materials, it has a nice gel set as well. If you're careful with the wave technique and you don't spend too much time waving it over the provisional and flowable cement interface, that you can get a nice gel phase, and then you can just peel off the excess flowable, floss it, and then give it a final cure. And it works as a great provisional cementation technique, as long as you're only spot etching, you're not total etching the tooth, and you're not using an adhesive that would create a stronger bond to that tooth than you would expect. Other techniques, of course, we're filling voids in provisional restorations, and it's enabling us to perfect bisacryl inside and outside the mouth, and do some really cool customization of provisionals with tints and stains and that type of thing, but just using the flowable to add a length, fill a void, change the contour. Daily practice, these are the ways I'm using flowable for everyday and aesthetic dentistry as well. And and having fun. If for some people, this is like dental porn. Seeing something like this, seeing highlights being placed on composites, and seeing tints and stains being used in the fissures. I mean, for me, this is the kind of stuff that turns me on in dentistry. I love this stuff, but today it's about the effectiveness. It's about everyday dentistry. It's really about getting efficient, getting consistent results, tight contacts, no post-op sensitivity, and things that we can really depend on in our practice that help out our workflow. So it turns out that the most popular use of flowable is as a thin, highly adaptive cavity liner. In vitro studies have shown that the use of flowable composite reduces restoration microleakage and the occurrence of voids that may cause post-operative sensitivity. Now, a survey was done among 700 dentists in Germany, and it revealed that the majority of dental professionals, 78%, use flowable composites as a liner underneath posterior composite resin fillings. So if you use flowable as a liner underneath your fillings, you are in the majority. But it's 78%. So it turns out it's not everybody does it. So it's actually kind of a little bit of a controversial subject. And so the question is, are you supposed to flow underneath these restorations or not flow, right? To flow or not flow. And so just pulling the literature, you see two different sides of the spectrum as far as whether or not a flowable liner is warranted. Do you need it? Don't you need it? And so anytime you see in dentistry, you see that much of a debate as far as what to do, what not to do, to me, it makes me feel as though there's more than one right answer. And so when I see that there's more than one right answer, it really would appear that whatever works best in that clinician's hands is probably the way to go. So, and for me, a flowable liner is what works best in my hands. So flowable resins may reduce sensitivity by another mechanism, acting as a buffer between the tooth and universal composite, obturing any areas of inadequate seal from adhesive placement. And to me, this is really the reason why I started using these flowable liners, because I was concerned I was getting these pocket of air between my composite and the adhesive interface where I wasn't getting a good seal. And in pulling studies, some studies have shown decreased microleakage when flowable composites are used as a liner at the gingival margin. Others have discouraged the practice. Some research has concluded the location of the gingival margin, either above or below the cemento-enamel junction, is the most important factor in determining the best restorative material to use. In these studies, glass ionomer cement has been suggested because of its adhesion properties and lack of shrinkage over flowable composite to prevent microleakage in areas that are below the cemento-enamel junction. So different techniques as far as filling these restorations. When you pull together the results of these studies, it appears that the use of flowable composite as a liner in the proximal box is recommended to increase cavity adaptation and reduce microleakage. So that's what I'm going with. If we look at SEM images, just two images side by side, we see that, that the paste in the left side, without using a flowable resin, there's some air pockets there. And in the right side, you see that there's a flowable composite layer between the dentin composite and the adhesive interface. If the paste composite doesn't fully adapt to the surface, it can leave these little pressurized air pockets that create sensitivity to the patient when biting. That's really the one thing that really turned me on to using flowable composites in my practice, is that I would have these patients come back not just with cold sensitivity, but when they bit down on the tooth, they would get a sharp pain. And I didn't know what this was coming from. And so finally I started testing it in another way. So when I tested in my office, the patient says it hurts to eat on the tooth with a new filling. So we need to know, is it the tooth that is inflamed from treatment? Is the filling high in the occlusion? Or is it a void at the restorative interface? After the occlusion is checked and adjusted, the patient reports no pain on tapping the teeth together. So then I simply take an instrument that's stronger than Explorer, like a scaler, and I push directly over the filling itself. If that elicits pain to the patient, but no pain when the patient taps on the tooth in occlusion, then the only thing that I can do is to remove the filling and replace it. So that's when I start talking to the patient about replacing the filling. And that's what I would do. If the patient came in and it hurt to eat on the tooth, if I took an instrument like a scaler and pushed down directly on top of this filling, and that elicited the sharp patient who says, yep, that's it, that's what's bothering me, then the only thing I can do is say, deal with it for a few months because it'll probably get better. Or really the right thing for me to do is just take the filling out and do it again. And so that's what I would do. And I hated that. I hated to have to do that. So I found that since I started using the flowable materials underneath my fillings as a cavity liner, that had completely gone away. So I wasn't getting any more of that pain on biting on a filling. So I made that switch to using flowables routinely underneath my fillings, and I just never went back. And so that's my story. So let's talk about the next phase. So the bulk fill flowables. Recent advances in monomer technology have ushered in a new category of bulk fill flowable composites that are designed to address material shortcomings of earlier products. So the new category of bulk fill composites, it promotes the effective use of 4 millimeter increments while decreasing shrinkage stresses generated during polymerization. That's awesome. So as before, I was so careful about placing my flowable in these small increments that I wasn't even sure I was totally covering the floor of the restoration. Now they're telling me with these bulk fill flow materials, I can just go at it. I mean, I could just go at it and have a good time of it. And so I love the fact that I get the ability to place it in larger increments and not have to worry about the shrinkage factor that causes so much problems for us in restorative dentistry. How do they do it? How do bulk fill flowables do it? Because there must be something different in the formulations, and each company that offers their flowable material has a little bit different way of reducing the shrinkage stresses. There's patented shrinkage stress reducing fillers. There's polymerization modulars. Resins that form more relaxed networks. There's shrinkage stress relievers, things inside the fillers that help to reduce the shrinkage forces on these restorations. And so what are the results then from the studies? People obviously are doing studies to see, is this true? Can this be true? So in pulling the results from the literature, we're seeing that 4 millimeter increments placed in high C-factor preparations did not compromise bond strength secondary to shrinkage stress. That's awesome. Bulk fill low shrinkage flowable resin can be used in an open sandwich technique without a negative impact to marginal dentistry, and so marginal integrity. So all these studies are concluding that we can use bulk fill flowable materials. And that's great. More studies. Cuspal deflection and deformation were studied in class 2 preparations. After restoration, cusp deflection was measured and found to be reduced by greater than 50% when the flowable resins were used. So these are all great news for us, for people who like efficiency in the practice. And it turns out now there are more and more companies, all major product companies, most major product companies are getting into the business of bulk filling and bulk filling flowables. There's a chart here to go over that kind of does a little comparison of some of the flowable, bulk flowable materials and traditional flow materials that are out there. And just to point out, some of the highlights of the chart, just to go through it, we want to look at depth of cure. And we see that across the board, these bulk flowables, the depth of cure is 4 millimeters, all pretty much the same there. So we're really comparing pretty much the same thing there. As far as translucency, next on the list on the chart, what we're looking for translucency depends on the usage of the material. Bulk flowable materials would be used as liners under restorations. The number one usage for this material would be liners under restoration. So when I think about what I want my translucency to be when it's underneath a restoration, I would think that it should be as close to dentin translucency as possible. So if it mimics the translucency of dentin, then my layer that goes on top can mimic the translucency of enamel, and I'll get the most aesthetic restoration. So what happens in these bulk fill flowable materials is that we need to be able to get light to cure 4 or 5 millimeters from the surface of the tooth. And so in order to do that, a lot of these materials manufacturers have gone to more translucent flowable materials to be able to get a deeper depth of cure. And so, unfortunately, it's counterintuitive to aesthetics, because if we get a highly translucent flowable, it's great for depth of cure, but it's ugly for aesthetics. And as you know, most restorations, especially involving when you're removing amalgams, we have stained dentin, secondary dentin, and we need to hide that. Because if we don't hide it before we put in our fillings, patient looks in the back of the mouth, sees gray, right? And so that's one of the few things that we can't do for efficient, predictable, everyday dentistry. We can't provide gray fillings. And so we really need to use a flowable material that has the translucency of dentin for aesthetics. So what's one of those important factors that I need to have in my practice? So, and it turns out that the translucency of dentin is around 9%, 9.8%. So the translucency of the Tetric EvoFlow bulk fill is around the translucency of dentin, so it works out nicely. Curing time across the board is about the same, so we're not really comparing curing times. And just so you know, just as a clinician, that 10-second curing time, by the way, it's with a very good LED light. LED lights are not all the same. There's certainly a difference in power between LED lights. I use the Ivoclar's Blue Phase style. It's a strong LED light. It cures everything, but also the important thing is that it's strong enough to get a deep cure in the 10-second time period. But even though as a clinician, and I know that they say 10 seconds, 10 seconds is ideal situation. Ideal situation. That light tip is on that tooth and it doesn't move for 10 seconds and it's in close proximity. And in real world, I know that's not necessarily the case, so I cure these materials for 20 seconds. It's an extra 10 seconds. I can handle it in my practice. So just to make sure it is fully cured. It's over-curing it, but that's okay. Volumetric shrinkage. So if we look at the volumetric shrinkage across the board, it's pretty much the same. And it turns out all these volumetric shrinkages are well within okay limits for utilizing for the technique that we want to utilize it for. Same thing with shrinkage stress, same thing. It's well within limits for utilizing for our restorations. Working time, when you compare the working times together, in this application, working time really isn't a big factor in my mind, because placing a liner underneath a restoration shouldn't take you but a couple seconds. And if it takes more than a couple seconds, you may want to change your material, because these types of materials could have a great flow. And so one of the things I like about Tetric's EvoFlow bulk fill is that it's got this self-adapting technology going on, where you can place it in the box, you can place it as the liner, and you can just watch it flow in. And you kind of have to, the assistant keeps wanting to hand you the Explorer at this point in time, because they're used to you taking the Explorer after you place the flowable liner and moving the flowable around, to make sure there's no voids and you filled in all the cracks. And when they pass the Explorer to you, you can just smack their hand. You say, to put that away. I don't need that anymore. And as far as the radiopacity, that's another important factor to me. I do want to be able to see it on a radiograph, obviously. I don't want it to mimic the radiopacities of dentin or enamel. The dentin is about 100%, enamel is about the 200%. So if you see the radiopacity over 200%, that means it's going to be brighter on the radiograph than both dentin and enamel. So easily distinguishable. So Tetric EvoFlow bulk fill does that as well. And then lastly, the shades. And so in posterior dentistry, efficient workflows, we want materials that match, that enable us to be able to create dentistry that has the effects of disappearing into the tooth. But I don't want to stock 50 shades of flowable liner. Okay, I just don't need it. You give me one that's the A shade, you give me one that's the B shade, you give me a whiter one for pedo teeth, and I'm good. I'm good. I just don't need to stock all these different shades. So I have, so I just stock these 3 different shades, and then and that's it. So we don't have to worry about the ordering. It's much, much easier. So let's talk about the way Tetric EvoFlow bulk fill does its depth of cure, because all the other materials are translucent, and this is the only one that's not translucent. The way it does it is something called Essentio technology, and the first time you see it, it's the coolest thing ever, because most of the time materials, if you're used to trying to opaque something out, you'll place like a Flowable over it, and you say, oh, that looks pretty good, right? And then you cure it, and then you can still see through the Flowable material, like you can still see the discolored dentin or whatever metal that you're trying to hide. And so that's the reality of it. We're used to seeing materials get a little more translucent after you cure them. This material is the opposite, okay? So it starts out translucent, and then you hit it with the curing light, and it gets more opaque. And that's Essensio technology, and that's the reason why we can have an opaque flowable liner that has the same opacity as dentin, the same translucency as dentin, but still get a 4 millimeter depth of cure. And I just think that is just the coolest thing ever. Another reason why I love the product, I'm sorry, I just want to show a video as I can. I have a video here of the Essensio technology at work. I'm going to run this video. So in this video, you'll see that there's a before and after polymerization, and this is a 10-second cure time with the blue phase style. And you'll see a high translucency in the beginning, that's before polymerization. And then 10 seconds later, you have less than 10%, so you get that dentin-like translucency, right? And so you can see those lines were obscured after curing. And so that's Essensio technology at work, okay? Another thing that I want to show is how the material self-adapts. And so this is why I was saying that you can tell your assistant to put the Explorer away, right? You don't have to make sure that the Explorer is carrying the Flowable into all the nooks and crannies to, make sure there's no voids, make sure we don't have any air pockets now. What we can do is just start placing the flowable material and just let it flow. Just let it flow. And so you'll see on the left, Tetric EvoFlow bulk fill, and on the right, Tetric EvoFlow. And so Tetric EvoFlow, it has its place too. Class 5 restorations, abfractions, NC, non-carious cervical lesions. You want to build, different areas of provisional. You want to fix the provisionals, bischrom provisionals. That makes sense, right? You don't want it to self-adapt. You don't want it to flow as like in the same way that Tetric EvoFlow bulk fill does. You use Tetric EvoFlow bulk fill with that type of technology, you use it as a liner for your fillings. And so that's how that works. So let's talk about, let's show a case. All right, so this is like everyday dentistry, We spot this in hygiene. Class 2 cavities. Somebody's got some class 2 cavities between their first and second molars, and it's almost like, this is something like it's every day, but you almost kind of dread it on the schedule because it's one of these things. It's like, is this going to be sensitive? Is it going to be cold sensitive? Is it going to hurt to bite on? Am I going to get good contour of the filling? Am I going to get good contact? And when do we know that? When we floss it, we can tell there's no contact. We just kind of pray that it comes together on its own somehow, or we got to redo it. How does that kill the schedule when you have to redo a filling you just did? Like, do you have time to do that filling twice to get proper contact? Another patient's waiting for you and hygiene's waiting for you. So it puts stress on you that it's got to go right. Getting proper contour, taking the ring off, taking the band on, you see your contour's not good. And you gotta, and in your head, that's not right. The food's going to get stuck there, but time is up, and you got to bring the patient back to fix that. And ultimately, when do you see if something's good or not? On an x-ray. And it's just on a radiograph, and it's just crazy that, we can be like the best dentists in the world, and we can have perfect preparations, and we can spend the money on the materials, and we can think we do everything right. And then where are we judged ultimately? It's like the finish line of a race. You can train for a race and you prepare properly. But what matters is the time when you cross the finish line. What matters is at the finish of the race. What matters is what your restoration looks like on an x-ray. And you're judged by that. You're a good dentist or a bad dentist by your x-ray, which is crazy, but it's true. And so ultimately, we see the same patient at a hygiene check. We take a bite wing and we look and we see, what do we see? We see a voided margin interproximally. We see that we've gouged the tooth next to it, right? And then the judgment starts, right? And so these are the things that cause the stress, so what I want to do is I want to remove some of this stress, and I think for my workflow, I've done a good job of reducing the stress that I have in these types of restorations. And so that's really what this case that I'm going to show you is about, is the way I reduce the stress, get it predictable, and get it efficient, and make sure that the color is going to be good for the patient, right? So let's run through the case. All right, first deal, prep design. The first deal is with prep design, right? And with the prep design, I just want to note that I'm using something here called a fender wedge. This is a Garrison product. It's called a fender wedge. And so what it does is it does a couple of things. It's pre-wedging, so it's separating the teeth. And when you separate the teeth, one thing you're doing is that you're gaining a little bit of extra space there. So when you're finished wedging, the teeth will come back together, and create that tight contact. But I really like it because it separates the teeth and it keeps you from inadvertently nicking the adjacent tooth if you're not intending to prepare it, right? If you don't want to start a crown prep on the tooth next to a filling, the fender wedge is a nice thing to have in the practice. And in this technique, I'm using it a lot as demonstration, because when you're doing two cavities or two fillings next to each other, you can really go to town there, right? And so you can create two symmetrical boxes, as long as they're symmetrical, you're good to go. But say in this case where I brought the finish line more lingual of the first molar, well, in order to do that, having the fender wedge there was protecting the adjacent tooth and allowing me to keep that prep design as conservative as possible without nicking that tooth. When do I really love it? Pulled it out today when I'm preparing a class 2 cavity filling against a crown. And those crowns with those extra long contacts, sometimes they can be really long contacts and you're in danger of nicking the porcelain on the adjacent tooth. So I use fender wedges a lot in my practice. So let's talk about the matrix. This is the 3D XR slick band that you're seeing a picture of. It's got a great contour to create the contour of the filling. And that's important to me, is that we get a nice, great contour. There's several sectional matrix bands on the market to choose from, and I just think the sectional matrix band is absolutely, of course, the way to go. This ring that you see, the composite type matrix ring, the 3D XR ring, is like my favorite thing to use for my class 2 fillings. I had the previous model, which had an orange silicone. This one has a blue silicone, and this ring is really great. It has a soft face technology, this thing will stay in place, right? The tension's retained. I've used it like hundreds of times, and it keeps going back to its normal shape. My original model, the orange one, didn't do that, right? So I still have that one in my practice, but when I put it on over the teeth, it doesn't hold very well, right? But the blue one, right, the 3D XR, it's great for short teeth, primary teeth. It can be malpositioned. It can be a class 2 involving a canine, and it can even be placed on top of a rubber dam clamp, right? And it stays in place, right? It doesn't pop off, and it is tight. It is tight. So if you want to get good tight contacts, that ring from Garrison is awesome. They did come out with a new wedge, by the way, too, which I just got to try, and I think is super cool. It's got that soft feel touch silicone on the outside of a hard core. So when you put it in there, it kind of adapts to the tooth as it goes in, and you get a nice hold of the matrix band in that way. So techniques, awesome. When you look at it from the side, you can see that it has a place for the wedge to be inserted. So the wedge goes in first, then the ring actually goes on top of the wedge, not next to the wedge. So you get a good holding power on the teeth that way, and you get good contour of the band. As far as etching technique, I selectively etch, right? And for selectively etching, a phosphoric acid is applied only to the enamel area, and a self-etch adhesive is used. This allows you get a deep acid etch on the enamel margins while you're maintaining the benefit of the self-etch product. You get that low post-operative sensitivity, and you get moisture tolerance on the dent. And so that's one of the things I love about the adhesives, self-etching products, universal adhesives, It includes low postoperative sensitivity. And you get that moisture tolerance on the dentin about, worried about, is it moist, is it wet, is it dry? So you get more tolerance in that manner when you use the universal adhesive. It reduces your chance to over-etch the dentin. As you know, when you over-etch the dentin, it creates a layer that is not permeated by the resin in the primer and allows fluid movement in the tubules. And that patient experiences that fluid movement as pain. And it also could reduce bond strengths. Right? And so after you rinse this etch off, it's time to place the glutaraldehyde desensitizers such as Gluma, such as System desensitizer, which also has glutaraldehyde and PEG-DMA. These different ways of antibacterial ways of treating the teeth and reducing sensitivity. Okay, so let's talk about the adhesive step. So after you rinse and dry, and how dry do you get it? Well, if you're using a universal adhesive, there's almost no wrong answer. I don't leave it super really wet. But I also don't really mind over drying the dentin at this point either, because the universal adhesive moistens, re-wets the dentin for me. The adhesive of choice that I use is the Adhes Universal, the Viva Pen. It is a universal bonding agent, which means in this term, because is there a really good definition for universal adhesive at this point? Because every product company kind of has their own definition of what a universal adhesive does. For this product, the Ivoclar Adhes Universal product, it's for direct or indirect. So I can use it for fillings, right? Direct fillings, or I could use it for indirect, indirects, cementation. So it's dual cure or light cure. I can use it for total etch. I can use it for selective etch, or I can use it for no etching at all. It also comes in a traditional bottle form. Now, I prefer the pen over the bottle form. Like, I'm totally hooked on the pen. It's a really convenient way to deliver the adhesive. It's ergonomic to hold. It's really easy to hold. It's comfortable. Allows you to supply the adhesive under your control, your speed, and it actually reduces material waste too. You get about 190 applications with 2 millimeters of adhesive in the pen. So, and it gives you fresh material every time. And that's a cool thing, right? And so if you're applying the adhesive to the tooth and you want to apply a little bit more, you just click the button, right? And you get fresh adhesive. You don't have to, motion that you need more. You don't have to hold your brush out, for the Dappen dish that has, the dispensed bottle in it, that's been sitting out for how long, that's evaporated, and so it's fresh every time. So I like that. I like the consistency there. So next is the flowable step, and this is what this is all about, right? And so with the placement of the flowable liner, I don't have to gingerly place the flowable, right? I don't have to just place this little bit and make sure it doesn't, get too thick or create the void somewhere and get into the crevices. And you can just kind of just do it, which is just such a good feeling. You can just dispense the flowable. You can make it up to 4 millimeters deep. My preference really is to give it enough to replace dentin in these instances, and for aesthetics, and then cure it. No need for the Explorer. No voids can get created because it adapts so nicely to the cavity walls. And my curing, by the way, blue phase style. Curing with blue phase style, it's ergonomic. It is a lightweight light. It's a lightweight light. It's broad spectrum. It cures everything, and it's an intense light. And as I already mentioned before, all lights are not the same. So recommend getting a good light. Do your research. Make sure the light cures everything. It's got to be easy to use. I've had my lights for a long time now, and they go through a lot of curing cycles with me. If I'm light curing full mouth rehabilitations, it gets a lot of use. And so it's nice that you can take the battery out and you can plug it into a wall without any downtime. You don't have to, if your battery does run out, you don't have to go into another treatment room looking for another light. How many LED lights do you have? You may pull an old halogen out of the closet. I don't know, but being able to just plug in the LED light when you run out of batteries is also a super cool thing. And I know the product manufacturer, says 10 seconds, but my safe zone is really closer to 20 seconds. So I cure for 20 seconds routinely with all these materials. And so after the flowable layer is the placement of, for me, I use Tetric EvoCeramic bulk fill. Tetric Evospray and Bulk Fill is my go-to product for posterior restorations because, again, I don't have to worry about incremental curing. It's got a nice chameleon-like effect, so I'm worried about the aesthetics. And, and it's got a great polishability. It's easy to place, and it's sculptable. So my go-to product, those are my products incrementally that I'm using for placing fillings in the posterior to get consistent results. So when I take the matrix off, evaluation of the contact area happens. I'm checking for flash. I'm checking, contours, things like that. And this is routine. This is pretty much what I see every time. Contacts usually a little bit too tight, and so kind of hard to get floss through. And so a lot of times what I'll do is I'll even go in and, I'll take discs and things to kind of shape around marginal ridges if I need to, and, check contacts, check occlusion, and just make sure that we are good to go. And just immediate post-op removal of the rubber dam, occlusions addressed, and this patient's good to go. So that's the way I do my posterior restorations. Those class 2, those class 2 fillings, love them or hate them, they're a part of dentistry, part of everyday dentistry. And so that's the way I do it. And so an immediate post-op on an x-ray, as I said, we're really judged by the x-ray, and so I just want to point out, that we've got good contour, and especially want to point out the radiopacity of these restorations. They're clearly able to see these restorations in the teeth, and so you don't have to have a pit in your stomach, when the patient comes back for hygiene and you're checking them and you're like, you tell your hygienist, did I do that one? Tell me I didn't do that one, as it happens to all of us, and so it's a good feeling when you can place restorations and you say, yes, that's mine. I can tell that's mine. Right. And so that's a good feeling. And so I feel like, not just being efficient, but it's predictability about utilizing the right products, products that don't give you voids, post-op sensitivity, products that are able to create those tight contacts with proper contour. It's the product, it's the technique, and it can make dentistry a lot more enjoyable. So let's do our summary here about things that we talked about. Flowable composite materials are less filled, less viscous materials that can be syringed into small preparations. Because of their high shrinkage and low wear resistance, the choice of applications for early flowables should be limited. Each incremental depth should not exceed 2 millimeters. Volumetric shrinkage of composite resins remains a clinical concern and should be carefully considered when choosing materials or restorative techniques. The utilization of incremental filling techniques is recommended to minimize shrinkage stress during composite resin placement until we come up with the bulk fill. So the use of flowable composite resins is recommended to seal the gingival margin of the proximal box in class 2 preparations, and also maybe consider below the cemento-enamel junction, considering the use of a glass ionomer cement. The low-stress bulk fill flowables are capable of being placed in 4 millimeter increments without increased cuspal deflection or loss of marginal integrity. It is important to note that bulk fill flowable resins do not provide improvements in marginal quality or cavity adaptation over earlier flowable composites, but they don't negatively affect it either. But they sure do help increase the efficiency and, with Tetric EvoFlow, the aesthetics as well. The use of dentin opacity is beneficial for aesthetics and efficiency, and it's beneficial to have a radiopacity that is significantly more than that of dentin enamel, so you can see it on radiographs. And so that concludes the presentation on flowables for everyday dentistry. I do have some questions here, so I'm going to field the questions and see. Hopefully I can give you some good answers. If I can't, I'll just let you know, but I'll do my best. And so first question, there you go. It says, is gluma applied after etching and before bonding? Yes, it is. Very good question. So yeah, I tried to go over that in the technique that if you're applying, by gluma you mean a glutaraldehyde or desensitizer. Yes, that's placed after you etch, right? So you're excuse me. So you're re-wetting the dentin the dentin, and you're carrying that glutaraldehyde to the tooth after you etch. Any other questions? Scrolling through. All right. Here, one question. This is a good question. It says, going back to slide number 31, what is the distal box margin pink color? I expected 31 for that. Margin pink color. That's purple. So that's the color of the band that you're seeing there. Yeah, so the band is, they're color coded so you know the size when you pull it out. And so that's the color purple. Okay. When a contact is too tight and patients return complaining about the tight contact, how do you make the contact less tight? So that does happen from time to time. Fortunately, it doesn't happen that much. So I make the contact less tight. I use discs in my practice, sanding discs that are thin, like a Cosmodent disc, a Flexi disc, like in that nature, or something around those lines where you can contour the margin and roll the margin. And usually when the contact is too tight, I found that it's just starting the floss is the most difficult thing. So opening up the embrasure space between the two teeth helps a lot. Also, any type of a sanding strip, like a lightning strip, if you can start to get that between the teeth, a sanding strip, then you can just lighten that contact a little bit. If you're having trouble getting that between the teeth, then you can wedge the teeth and start your sanding strip process after the teeth have been wedged, or take an instrument and gently separate the teeth, getting the lightning strip between the teeth, and then use the sanding strip once the teeth have been separated a little bit. Okay, there's a few other questions. One of the questions is, how long does the blue ring last? And so the blue ring lasts a long time. I don't know the answer to how long the blue ring lasts, because the 3D XR matrix ring, that's the Garrison product that I use, I'm still using the same ones that I bought. It's been a long time. So I don't know what the lifespan is going to be for me, but I'm assuming it's going to be a very long time, because those things are like super, super tight. Do I ever get sectional matrix locked between the two class 2s? These sectional matrices are a non-stick. They have a non-stick surface, and that is super beneficial, because when those matrix bands get stuck, a lot of it's because of the adhesion of the composite to the matrix band, not necessarily the tight contact. And so it did happen in the past. These types of matrix bands do help a lot because they are coated with a non-stick surface. That's what the purple color is, that non-stick surface. And so it keeps the band from sticking to the composite and makes it a lot easier to remove. So I'll take one or two more questions, then we'll call it a night. Let's see, got that one already. I see more and more questions are coming in. I think that's awesome. I love asking the questions, answering the questions. Do I put Flowable first under a bulk fill? I do, and that's just because that's my technique. And so Tetric Evoceram bulk fill doesn't require a flowable first, right? But you can't use any flowables. You can't use all the way to the surface of the restoration, because they're not built for that. They're not strong enough. They don't have the wear resistance. You can't make them occlusal bearing restorations. You have to put a capping composite over a flowable material, right? Any of the bulk fill flows. So so you carry it within 2 millimeters of the surface, then you put your capping composite on. But you don't have to, right? And so Tetric Evoceram bulk fill is a material that I can use, right? And so I don't have to buy any special instruments for it. I can place it in its cavity form. I can place it, inject it into the tooth, and it's monolithic, right? And so with Tetric Evoceram bulk fill, I don't need the flowable. I can cure it 4 millimeter increments. And so if my restoration is 4 millimeters or less, it can just be a one monolithic restoration. right? Just tetragreaves ramp bulk fill, that I can fill the full contour, sculpt it, and then cure it, right? So I don't have to use a flowable underneath that one. Okay, and so a few questions coming up about utilizing glass ionomers, RMGIs. You know, will you still use flowables in a deep proximal box where there's no enamel at the subgingival cable surface margin? So that's below the CEJ. That's referred to as the open sandwich technique. That we're putting a resin-modified glass ionomer down first. Then we have an adhesive layer, and then we go in with our restorative composites because of the bond of the resin-modified glass ionomer to the dentin would be superior in that instance for long-term integrity of that, and we get the fluoride release. So can we get in that technique an open sandwich technique? Yes. So if we have like no enamel to bond to, a lot of practitioners do turn to resin-modified glass ionomers when we're talking about class 2 restorations below the CEJ. Do I turn to it all the time? No, I don't. It's a very specific time which I would turn to it, but usually I don't. Usually I go with my traditional practical protocols that I showed you today. But that, again, you know, some people really love to place the resin-modified glass ionomers in these situations. So it depends on the user's hands what you prefer to use. And then let's take one more question here. We're running out of time. This question says, for the broken temporary veneer, do you spot etch and spot bond, then cure flowable? So I do spot etch. So I'll get a little bit more retention by spot etching a tooth before cementing on a provisional veneer with a flowable. And that spot etch, we're talking, you know, 3 to 4, maybe 5 millimeters at most in diameter, dead center of the tooth. And you got to make sure that's dead center of the tooth, and be careful cleaning it off with the water syringe and the suction, because if that etch gets all over the tooth, then when you take off the provisional, you can have remnants of the flow on different parts of the teeth. When it's always dead center, it's very easy to clean off any remnants right away. As soon as the provisional comes off, you could take something like a disc or a polishing burr or a diamond and just polish the dead center part of that tooth, and it's cleaned off. Do I use an adhesive? You have to be careful with the usage of adhesives. I wouldn't use a universal adhesive, right? I'd be very careful about that, because that's going to self-etch, right? So I don't want to self-etch. This would have to be something like a 5th generation adhesive, and if you combine that with spot etching, that thing's really going to stay. All right, it's going to stay really, really well. Have I done it before? You bet. Sometimes I want a single provisional veneer to stay, right? So I'm spot etching dead center. I'm using a little bit of a 5th generation adhesive, and I'm being careful. I'm even keeping it away from the margins. I'm keeping it away from the incisal edge, but I'm using it some very, very scarcely to help retain the provisional veneer. But you got to be careful with that technique, but it really will hold on a single unit provisional veneer very well.